for standing by. At this time, all participants are in a listen-only mode until the question and answer session. At the time to ask a question, you may press star 1 on your touch-tone phone. Today's conference is being recorded. If you have any objections, you may disconnect at this time. And to turn today's meeting over to Ann Herron, thank you. You may begin.
Thank you, Candy, and welcome everybody. I'd like to absolutely welcome you to our webinar on the discussion of projects that are currently being undertaken that we think may be very interesting to you and helpful to states and providers as we look to improving the behavioral health workforce. Myself, my name is Ann Herron. I'm the Director of the Division of Regional and National Policy Liaison for SAMHSA. I'm also our lead for workforce development. We had the great pleasure this last year of working very closely with our partners at HRSA, the Health Resources and Services Administration, to sponsor what is the first research center that is focusing on the behavioral health workforce. And we're thrilled to have the University of Michigan speak with us today and tell us about some of their projects. Before I do that, I would like to introduce you to my colleague at HRSA, Robin Streeter, to introduce our panelist. Robin?
Great. Thank you so much, Ann, and a big welcome, everyone. We're really thrilled that you all are able to join this afternoon and spend the summer afternoon with us. As Ann said, the University of Michigan Behavioral Health Research Center is a joint initiative between SAMHSA and HRSA. The center was set up to conduct health workforce research to strengthen the behavioral health workforce and support a workforce of sufficient size and skill to meet the nation's behavioral health needs. The University of Michigan Center is one of several health workforce research centers set up under the authorities from the Public Health Service Act as amended by the Affordable Care Act. And as Ann said, we're really excited about University of Michigan's current projects and about this joint venture between SAMHSA and HRSA. It's been a really rewarding experience so far, and we're thrilled to be moving forward with some of these projects. So with that, we look forward to your thoughts about University of Michigan's current portfolio and to your thoughts, what you'll be hearing this afternoon from Angela. And with that, I'll get rolling, and I'll turn it over to Angela. Thank you all.
Thank you, Robin, and thank you, Ann, for inviting me to present today. I'm Angela Beck. I'm Director of the Behavioral Health Workforce Research Center at the University of Michigan School of Public Health. I'm going to spend a little bit of time telling you about the Behavioral Health Workforce Research Center and the initiatives we're currently undertaking to try to strengthen behavioral health workforce capacity. We'll recap. Ann and Robin mentioned some of these things already, but we are the newest member of HRSA's Health Workforce Research Center network. We were established in September 2015. We're housed administratively at the School of Public Health in the Department of Health Management and Policy. We're a unique center among the HWRC network for a couple of reasons. As Ann and Robin mentioned, we are jointly supported by HRSA and SAMHSA, and we're the only center solely focused on the behavioral health workforce, although there are other HWRCs in that work that have done some projects on the behavioral health workforce, and so we have lots of opportunity for great collaborations with other universities and centers in our network. We also work through a consortium model, which I think is unique among the HWRCs. I'll introduce those organizations to you in a second and let you know how they're involved in our efforts. At the University of Michigan, our core research team is interdisciplinary. We have faculty with expertise in public health systems research, behavioral health services, social work, and qualitative methods. Our research team, our Deputy Director, Dr. Bolton, and I, our backgrounds are actually in public health systems research with an emphasis on the public health workforce. So behavioral health is a little bit of a new field for us, but I think as we developed our proposal for this center, we were struck by the similarities and the challenges between the two fields, behavioral health and public health, when it comes to workforce research. So, for example, both fields have a very diverse workforce represented by lots of different occupations, types of workers, skill levels, and so on. Both also have pretty poor data collection at the moment, actually. So lots of challenges related to defining workforce and trying to identify appropriate methodologies for collecting data in a way that we can continuously monitor the workforce. We have Brian Perrin as a co-investigator on this project. He's faculty in U of M School of Social Work. Kaiser is an investigator in the center. She's in the Department of Health Management and Policy and has expertise in integrated care. And Elizabeth King serves sort of our qualitative guru, as many of our research projects have a qualitative component. We have 4 key staff associated with our center. Jesse Boki is our program manager, and Monier is our administrative assistant. Phil's a doctoral candidate in our department here and serves as a research assistant, and Corey Page is a master's student graduate research assistant for us. So our research team works with our partner consortium. You can see here that we have a list of 7 external organizations that have agreed to work with us over the next 3 years of our project. By the National Council for Behavioral Health, which is also a subcontractor on our project and has really taken a key role in helping us implement our work plan. But as you can see, our partner consortium is represented by folks on the substance use disorder side, the mental health side. We've included our public health partners in this as well. And these folks are really committed to helping us think through what research questions are important for the field, so that there's not just academics sitting in Ann Arbor trying to decide what research questions are important, but that we're actively getting guidance and facilitation from folks in behavioral health, what would be useful to move the field forward in terms of workforce capacity. They're very helpful to us in helping implement our study designs, and we'll be helping with dissemination of findings when those come around in the next few months here. So anticipate that as our center engages in additional research projects over the next few years, this partner consortium list will continue to grow. I want to mention that we have a couple of key consultants who have been incredibly helpful with the work of the center. Ron Manderscheid, formerly of SAMHSA, is a consultant here. He is now Executive Director of the National Association of County Behavioral Health and Developmental Disability Directors. He provides a substantial amount of subject matter expertise for our work. And Peter House is a well-recognized health workforce researcher. Our main federal partners are HRSA and SAMHSA, who have provided wonderful guidance over this past year as we've gotten launched. So the question that really had to tackle as a center with our consortium partners is, what do we mean when we say behavioral health workforce? Who does that involve? And, as I'm sure you're probably familiar, the literature and, more importantly, for our purposes, the data around the behavioral health workforce has often been focused on the core licensed behavioral health professions that you would typically associate with behavioral health care delivery. Psychologists and psychiatrists, clinical social workers, licensed professional counselors, marriage and family therapists, and so on. We decided early on that we did not want to limit our research to those core professions. They're certainly important and included in our research activities, but deliberately made the definition of behavioral health workforce for the purposes of our center's research to include non-licensed workers, paraprofessionals, peer support folks, and so on. This gives you a little bit of a sample of what those job titles might be, although it's not an inclusive list, but more to give you an idea that there's some breadth to this workforce. They represent different types of functions and responsibilities and skill levels. There's varying levels of information available about them in the workforce literature currently. To kind of frame a little bit how we think about categorizing behavioral health workers when we think about workforce capacity and doing studies on size and composition, there are a couple of factors that often they're prominent in the literature, I would say, when thinking about categorizing the workforce. You can think of workers according to their settings. So settings that provide behavioral health services, you can look within employee group to see who among them our behavioral health workers. You can look at field of study. You can take a look at all clinical social workers, for example, and think of them as part of the behavioral health workforce. Studies focus specifically on occupation, so all psychiatrists, for example, as being part of the behavioral health workforce. And one that we're very interested in, though I think data is the least available on, is function. So what folks are doing in of behavioral health service delivery and using that as a mechanism for thinking through workforce capacity. I think if you use any one of these spheres or these factors, you have limitations in terms of what you can say about your workforce. What we're interested in is the overlap of all of these as being how we think of the behavioral health workforce and its associated capacity. Just a little bit more, if you look at health workforce plan models, you'll primarily see them based on occupations and on healthcare utilization. And those are certainly important models. We wouldn't want to eliminate those models, but want to take those a step further perhaps and try to think through models based on job function and unmet need for behavioral health services. So while often used, workforce planning models might look at trying to answer questions related to how many psychiatrists do we have, how patients were treated by psychiatrists, or how many psychiatrists do we need in the workforce. We also want to try to consider things like how workers are trained to provide psychotherapy in general. Do we have estimates of unmet need for psychotherapy? And collectively, what workers across the whole broad behavioral health workforce could fill this need? Sort of functional framework, that's certainly the underlying concept that we've tried to apply to our work plan. We contracted to complete 12 research projects per year as part of this center grant, and they are divided among 3 focus areas that SAMHSA and HRSA identified for us at the start of the project, and they involve development of a minimum data set, characteristics and practice settings of the workforce, and scopes of practice. And as we're in the first year, I don't really have findings to present to you quite yet. They are most of our projects, the survey are in the field right now, or we're in the process of data analysis. But I'm happy to summarize what each of our projects are this year and tell you a little bit about what we're going to do going forward. So one is related to development of a minimum data set, and this certainly isn't a new idea. This is a project that HRSA has been involved in for quite some time. This is a screenshot of HRSA's website of their health professions data set page. If you Google HRSA MDS, this will come right up for you. And so, you know, HRSA's been involved in trying to develop MDSs for health professions for quite some time, and there are a few behavioral health occupations that are included in the current list. Our job was to sort of think really about that big definition we have for behavioral health workforce and develop an MDS that fits the whole workforce. So the idea behind an MDS really is to identify a common set of data elements that can be applied uniformly across the workforce as doing data collection to try to improve comparability of data so that we have better data quality, we're better able to make workforce supply and demand projections and make recommendations around other workforce planning efforts. So I had 4 projects related to minimum data set. The first one I already touched on was this whole idea of who is the workforce and defining what that means for the purposes of our center. We tried to take that one step further by developing a sort of draft taxonomy that we're working from to get on the same page about terminology across mental health and substance use disorder professions and characteristics of those professions. And we've used that as a framework to develop our MDS instrument. Another of the MDS project involves identifying and evaluating data sources that could potentially populate an MDS. And we developed a draft MDS, and we will be pilot testing that with focus groups soon. In 2, we moved out of the development phase and start trying to get toward actual data collection. So we'll be looking more closely at social workers and marriage and family therapists. We're all going to be thinking through an implementation plan. So, we'll have this instrument that presumably has been vetted by our consortium, by external stakeholders, and pilot tested in focus groups. What do we do with it now? How do we make it available and accessible and widely used within the field? And then also going to work on developing an organizational level MDS. So MDS, a little snippet of it on your screen here, it's really meant to collect data at the individual worker level. And as you can see, it's somewhat structured as a survey. Data elements are kind of grouped into 5 main themes. So demographics, we're certainly very interested in for the workforce, education and training background, lecture and certification, occupation or area of practice, and then practice characteristics and settings. So we developed a very lengthy list data elements as part of this MDS that we think are important for making supply and demand projections and other workforce planning studies. In the process of trying to vet those with our partners. Our focus groups are planned for July. The other end of this project that I mentioned was looking at what exists already in terms of data sources for the behavioral health workforce, and we've identified nearly 150 different types of references for data sources. So perhaps they're surveys, perhaps they're reports, perhaps they're actual data sets, although those are certainly fewer than the documents that we found. But the idea is to try to determine, are there existing data out there that can populate an MDS system should we put one together. And we rated those data according to validity, reliability, frequency with which those data are collected, and accessibility of data. So, if all we can find is a report that summarizes findings, but you can't actually access the data, that's probably of limited use to us in thinking through ways to continuously monitor this worker population. So we'll have a deliverable at the end of this project year that sort of aligns those workforce data sources with the various data elements in the MDS. No data source covers all of it, and we wouldn't expect it to, but certainly there are potentially data sources that cover pieces of it. I also mentioned that this MDS, it will be fairly lengthy. It has several data elements associated with it, and it doesn't necessarily need to be used in full by every organization or licensure body or researcher who's interested in workforce data collection. Perhaps some elements are applicable to a certain study or information and some are not. But really the idea is that we promote a uniform set. We're all using the same terminology, using the same kind of study questions, and can better align our results. It has to do with characteristics and practice settings of the workforce, and in this area we're really looking at studies that focus on workforce size, composition, and mechanisms for service delivery. We're interested in focusing on specific persons and populations at times, which I'll mention briefly, and I think it's important to note that we're interested in both the current workforce and the future pipeline of behavioral health workers. Projects, which I'll go through in more detail, address workforce diversity, provision of services to vulnerable and underserved population, team-based care models, behavioral health competencies across professions. In year 2, we're change focus a little bit to include a set of the behavioral health workforce in correctional facilities. We're going to do a project with the HWRC at the University of North Carolina, Chapel Hill on understanding the role of social workers on integrated care teams. We're interested in workforce changes associated with healthcare reform, and we'll also be looking at telehealth as used for behavioral health workforce capacity. So one project, or progress, what we've done so far in our projects, for behavioral health workforce diversity, The purpose of this project really is to try to identify factors that are inhibiting growth of a diverse behavioral health workforce. We know that there are pieces of the population that are underrepresented in this workforce, and so, can we get at factors that could potentially intervene on to try to alleviate that disparity? So we're looking at things like recruitment, retention, workplace experiences, discrimination, education and training background of folks. And this is an individual level survey that we're issuing to behavioral health workers in Michigan. The survey has been piloted and should be going in the field within the next few weeks or so, having preliminary findings available for this study probably in early September. The project in this focus area is related to service delivery for vulnerable and underserved populations. This is an organizational level study, so workforce diversity was an individual worker level study. In this project, we're surveying healthcare organizations, behavioral healthcare organizations, that are providing services to rural and underserved communities to assess workforce supply and needs, again, recruitment and retention barriers, and to what extent they're integrating physical and behavioral health care within their organization. This study is based on two different communities, one in Southwest Michigan, which is predominantly rural, working with our consortium partner, Southwest Michigan Behavioral Health, to reach those organizations. Another setting is in Pima County, Arizona, which actually has a rural-urban mix, but also has Hispanic and tribal communities as part of that county. So we're very interested in how service delivery is occurring in organizations in that area as well. So we're expecting to find some variability across those geographic regions and in terms of how the workforce is being recruited, is being used to deliver services in these areas that are mental health profession shortage areas. Our project in this focus area is related to team-based care case studies. So we're doing case studies of 8 states across the country. We have interviewed key informants for each of these healthcare organizations. We're primarily looking at different models of integration of primary and behavioral health care, and we're really trying to look at this through a workforce lens. So what do folks have to do to train their workforce to implement these team-based care models? Perhaps there are best practices and lessons learned that these healthcare administrators can share that will help give us a sense of how we might better integrate the workforce. We know there are a lot of barriers. We know there are a lot of challenges, but we've identified some folks who are doing this well and are willing to share those lessons learned. Solely qualitative study. We've completed the interviews, the analysis is underway, and we should have an initial report of findings probably late next month. And the project in Focus Area 2 has to do with core competencies across behavioral health disciplines. So the goal of this project really is to take a look at competency statements in non-medical behavioral health professional disciplines. So, and look at the curriculum that's being used in these health profession schools that are training behavioral health workers. So we're non-medical, we're not looking at psychiatrists, we're not looking at nurses, but we're looking at other folks, social work schools, folks training licensed professional counselors and so on, and trying to look at that alignment between what kind of competencies are being recommended, are they uniform across the field, how are they being implemented in the actual curriculum. So Focus Area 2, Focus Area 3 relates to scope of practice. Scope of practice, I would say this focus area has been perhaps the most challenging in some ways. The 3 focus areas in terms of how much time it's taken to really get hands on all of these SOPs across the states. But when I talk about scope of practice, I'm primarily speaking the legal SOPs that delineate authority to perform certain tasks to states. There are functional scopes of practice that you might see promoted by professional organizations or credentialing bodies, and describe the various responsibilities and capabilities of different occupations. So overall, the concern here is that there's recognized misalignment of SOPs among behavioral health professions in terms of what they're authorized to do and what they're educated or trained to do. And that happens for a lot of reasons. Sometimes it's due to legal restrictions imposed by states, sometimes to do with billing restrictions or what's reimbursable for service delivery, and sometimes it has to do with protection of legal or functional authority by professional groups. So a good example of that is prescribing authority. That varies by state. In some cases, RNs have full prescribing authority in some states, and they don't. So that would be an example of a legal restriction imposed. That's also a pretty good example of protection of legal and functional authority by professional groups. There's often some activity around scopes of practice across the different professional groups, and understandably so. But those are issues that we're trying to work through and take a look at over this next year. Key research questions for this focus area, we're interested in for which professions are state scopes of practice accessible? What elements do they contain? And what is the variability of scope of practice across the states and occupation? And really the goal here is to provide greater accessibility SOPs to the behavioral health community as we approach professional organizations really looking for assistance with this and, can they help us find these scopes of practice? We've really gotten a strong response of, gosh, we don't have this information, but we're really looking forward to you providing this to us at some point. So I think this is information that will be useful to the field and that folks are looking for. And we also want to determine whether policy recommendations related to scope of practice changes are appropriate at all. Year one projects, we're doing an overall assessment of behavioral health scopes of practice. We're a little more in-depth assessment of social work scope of practice and paraprofessional scopes of practice, and we're also doing a project related to billing restrictions that may limit SOPs. Year two, we're shifting a little bit to focus on scopes of practice related to mental health, also looking at scopes of practice issues related to medication-assisted treatment, scopes of practice, again, looking at the population serving correctional facilities, and we'll do a little more work on licensed professional counselor scope of practice. So far this year, the big project in this focus area is just this overall analysis of state scopes of practice for behavioral health. So our purpose here is to review every state's statutes, administrative codes, certification programs, and job classification materials to identify scopes of practice, and we chose 10 behavioral health professions for this first year, which I should have written down, but they include a breadth of occupations, such as psychiatrists, psych RNs, licensed professional counselors, addiction counselors specifically, social workers, caregivers, psychiatric rehabilitation specialists, case managers, and peer support specialists. So we are trying to get a breadth of occupations involved in our first year here. As many scopes of practice as we think we're going to be able to do. So now we're in the analysis phase where we're looking at variables related to more of a macro state analysis, variables related to licensure, as well as available services. In state analysis, this just means we're logging information about the names of the certifying or licensing bodies for various occupations across the 50 states. We're noting things like when statutes were published, when they were updated or revised, and what the professional definitions are that are identified in these scopes of practice for these professions. So variables are in there to compare the varying qualifications of professionals in each state. They need to have to initially apply for licensure or perhaps renew licensure. So those would include things like supervised work experience, examination requirements, continuing ed requirements. We're also looking at some things like reciprocity across states for licensure. And billable services, these variables are looking at whether the SOP contains language that delineates what each occupation is permitted to provide by state, so diagnosis or crisis intervention or psychotherapy. For the first project, for these 10 behavioral health professions, the analysis is pretty much limited to does SOP include these variables or not? So it's more of a binary coding of presence or absence of all of these things across the SOPs. And we are finding variability and expected to find variability, but it will be interesting to see what that variability looks like as a whole once we get through the analysis. For the social worker scopes of practice, we're taking it one step further where we'll certainly be noting presence or absence of these things, but then we're also looking at content as well. So for the states that do include continuing education requirements as part of their scopes of practice, what are they about them and where is the variability there? For all. So this is the only occupation that we're doing this level of assessment on this year. The idea was kind of to try to test this model first before we roll it out to other occupations to make sure that the analysis is feasible to do and that this is providing useful information. It's definitely in our year 2 work plan to roll this out to other occupations as well. For different paths when looking at the paraprofessional scopes of practice, this will involve a cert that will be issued by the National Council for Behavioral Health. They're a lead partner on this project. And so asking paraprofessionals to tell us what their job functions and responsibilities are on a daily basis and going back and trying to compare them to the scopes of practice that we've identified. 5 professions that the National Council has selected for this project are community health worker, peer recovery specialist, case manager, health navigator, and addiction counselor. And I will say, a caveat here is we recognize that some of these professionals work at different levels. So not all addiction counselors would necessarily be paraprofessionals. So we're not actually framing the survey as a paraprofessional survey. It's more we're asking them what they do and asking them to tell us how they are trained and licensed, and then we can, on our end, try to determine, are they functioning at a paraprofessional sort of level, or do they have more education and training than that? This was just recently approved by IRB, so pilot testing will be occurring shortly here, and then we're hoping to have data collection occur in August. Project in our plan for this year has to do with understanding billing practices that limit scopes of practice. Again, the National Council is the lead investigator really on this project. So they're trying to document on a state-by-state level which types of behavioral health practitioners can be reimbursed for which types of services, primarily within Medicaid, although they're also going to do, we're going to gather some information on commercial insurance plans as well. So we're going to get at, this idea of a discrepancy between what the state scope of practice might authorize versus what insurance is saying is reimbursable and how that might be limiting what services are being delivered. In portfolio, in terms of future directions, we're going to continue to focus our work along several main themes, and certainly, hopefully, you saw that these were reflected in the year 1 and 2 projects that I mentioned. But our center definitely has interest in vulnerable and underserved populations, and an example being next year a focus on the workforce serving the population in correctional facilities. We're very interested in workforce factors that impact service delivery, so we continue interest in integrated care and team-based care models. We'll be adding telehealth to that mix next year. And of course, we will continue to do discipline-specific studies. We sort of came up with a core group of disciplines that we were comfortable starting with this year on a 10 or 12-month work period, and we'll be phasing out to include additional disciplines in year 2 and year 3. Just wanted to mention is, you know, I've presented a lot of different activities and studies that we have going on. And I think it's important, this was a suggestion of Ron Manderscheid, and I think it's a really excellent one, that all of these activities and projects align with the 3 focus areas that were identified by HRSA and SAMHSA, but we're going to take a little more time this year to think through strategic planning initiatives to align these projects with the mission and goals of the center and those of its partners, so that we're not, so that we sort of a research roadmap that the center can follow, not just for the center's purposes, but for the Behavioral Health Workforce Research Committee as a whole, if we can kind of try to come up with what our plan should be for behavioral health workforce research, and ensure that the projects that we're proposing in that sort of roadmap, so that we're all collectively working toward a common goal here in terms of improving workforce capacity. Ways to contact us if you'd like to. We very much welcome any feedback if you would like to know more information about our projects, if you have ideas for projects or for populations. Please do reach out to us. Our website is accessible at behavioralhealthworkforce.org. There's a little section in there where you can sign up for a newsletter, as we do a quarterly newsletter. As we have more findings coming out soon, we'll be getting those out to our newsletter listserv. We're also on Twitter, on Facebook, and you can reach us at bhworkforce@umich.edu if you have questions. So that's my end. Happy to answer any questions you have about the center or our project.
We could please open up the lines and let people ask any questions or make comments. And thank you very much. This was great. That was a really nice summary of the projects and activities. I appreciate that.
Great.
It's time to ask a question. Press *1, please. Please unmute your line and record your name to be introduced. For questions or comments, again, press *1. If you'd like to withdraw the request at any time, you may press *2. Thank you. A moment, please, for your first question. And comes from Renata Henry. Your line is open.
Thank you so much. This is a fascinating project and really very interesting. I am the executive director of the Danya Institute, and we have a contract for the one of the addiction technology transfer centers that serves HHS Region 3. So just a clarification on the peer support specialist, peer recovery specialist, and community health worker. As you're doing your scope of practice, I just want to make sure that I'm clear that peer support specialists are the scope of this as professionals, peer specialist under scope of practice for professionals. Did I not see community health workers in either one of those for scope of practice?
Community health workers are included. They're specifically being included in the project being led by the National Council, so they'll be included in the survey work that we're doing related to scope of practice. To answer your other question related to peer support specialist and peer recovery specialist, the peer workforce has been an interesting one for us, as we have found different terminology being used widely throughout the country. So I think, you know, it's been a challenge for us to kind of sort through the different terminology, and are they talking about the same type of job function? In some cases, yes, and in some cases, no. So I think the answer to your question is it kind of depends on which piece of the workforce we're looking at.
That's helpful.
If you have suggestions on how to sort that out for us, I would love them.
And just so I might have misheard, so the National Council is going to do the scope of practice piece with the community health workers.
Correct.
Have they been given professional, paraprofessional, or it's just different altogether?
We are trying not to lump folks into one group or the other. My sense is, I don't know that folks want that they self-identify as paraprofessional, for example. I would not want to place that label on them. So the idea really is that we are looking for folks who would self-identify as a community health worker or as a peer recovery specialist or peer support specialist, for example, and we'll take a look at what their functions are and responsibilities are, as opposed to trying to think in sort of this hierarchical professional, paraprofessional model.
That's great to hear, and thank you.
Mm-hmm.
For questions or comments, press *1. Next question we have is Patricia. Your line is open.
First of all, I just want to say what a fabulous presentation this is. It makes me hopeful for this area, and I have to say I wasn't that hopeful when I started the call. But that's not what I wanted to ask you. What I wanted to ask you about was an issue you've probably heard about. One of the hats I wear, actually two of the hats I wear, one is chair of the statewide suicide prevention group, and the other is chief social worker for the state mental health authority, state hospitals. And one of the things you've probably heard about is to do with competencies of the licensed professions with respect to people who have suicidal issues. And it comes as no surprise to anyone on this group that you can be a licensed professional in the mental health field in the states and not have to know anything about how to work with people who are suicidal. And this is hammered home to me when I'm wearing my chief social worker hat all the time. So I wondered if any of the work you're doing is going to be looking at that or at any issues that are relevant to that.
That's a good question. I'm glad you mentioned that. I think for our year one work plan, where that would be most relevant would be in the competency work we're trying to do, but really that's limited to licensed professions, folks that are probably at the master's degree level and higher. So missing a piece of the workforce related to competency there. I suspect it will come up as part of that project. That we're still doing analysis on that, so I can't give you a good read on how prominent that is right now. But it's definitely something I will look out for based on your comment, and definitely note as we think through year 2 and year 3 projects that this is an area of need in terms of research.
That's a really good place to start.
Thank you. For additional questions or comments, press *1, please. And we do have another question in queue. Stand by, please. Eric Brooks, your line is open.
Hi there. Thanks very much. I typed in a question as well that I'll just share over the phone. Wondering whether your study is looking at, or it's on your radar at all, to consider hospital-based mental health workers and similar titles, which, at least in my experience, are unlicensed professionals. They work in psych hospitals or psych units in general hospitals, and their responsibilities range from C type of duties, which sometimes they are CNAs, but often they have requirement of a bachelor's degree or greater, and they may have safety and security responsibilities, and they may have some sort of counseling or support as well. Is that something that is on your radar?
That would definitely fit within our definition. So really, I don't know if I stated specifically or clearly that the definition we landed on was really any worker involved in prevention or treatment of mental health and substance use disorders. So they would certainly be considered folks we're interested in. Are they specifically being reached in the projects that we're doing now? I'm not sure. Probably not to the extent that they should be. But they are definitely folks that we would want to include in our research going forward. I think part of what we've struggled with, they're not struggled with, but have had great discussions around as a consortium, is the importance of ensuring that this research center is representing a broad definition of what behavioral health workforce means. The challenge associated with that is to develop methodology where you can find all these folks, and it is a challenge. So I don't know that at the end of our 3-year project period we'll have hit every single group that we're interested in, but I'm hopeful that by the end of year 3 we'll at least have a pretty good assessment of where the gaps are. So if future funding is available, we can really think through what methodology we can use to hone in on those folks. So I appreciate comments like this so that we make sure it's on our list, that it's on our radar.
Great, thanks.
Thank you again. For questions or comments, press star 1. Our next question is Bill Stouffer. Your line is open.
So much. It's been such a great presentation. My name is Bill Stauffer, calling from the Penny Recovery Organization here in Pennsylvania. It's very good to see both addiction counselors and the peer support workers in the study. As you know, we're in the nation's worst epidemic with opiate problems, and it's really hitting our workforce hard. Question, I'm wondering if you've considered looking in your qualitative work on factors of why people stick with this kind of work. There's been a fair amount of research out there in the literature about barriers or things that are in the way, low pay, high stress, and things like that. But I'm particularly intrigued, and we've done some work to look at why do people stick with the work. And I suspect that it might help us target who may be interested in doing the work and moving into careers in our service line. So that's an area of interest for me, and I'm wondering if it's something you've considered.
Yeah, that's a really good point. I'm glad you framed it that way, because I think I mostly talked about the barriers associated with getting folks into the workforce. But certainly, we can learn a lot from why folks want to stay. I think that's really key. That is an element of some of our work this year. That's definitely something we can expand upon in the future as well to other disciplines. Yeah, I appreciate you bringing that up.
Thank you.
No questions. Again, for questions or comments, press star 1. A few questions in queue. One moment, please. Thank from Deborah Strad. Your line is open.
I help support the Massachusetts Bureau of Substance Abuse Services in doing addictions workforce development. And I wondered if you have any plans to study movement in the addictions workforce, because we see a lot of sort of recycling and movement, both lateral and promotions, but it's hard to tell where the expansion is going to come in any given moment. And I wondered if you have any plans to study both the sort of recirculation and its service impact as people leave a position to take a position and then leave a hole, and that takes a while to fill.
That's a really great suggestion. It is not in our current work plan. I think it's absolutely worth adding to the list, though, for consideration. I'm trying to think of other stuff that I've seen that potentially get at this, but I think you're right that type of research is pretty limited in this field. I've seen a little bit of that around the RN workforce or the BSN diploma to BSN, kind of movement in that regard in terms of educational level, but I haven't really seen any workforce studies that get at what you're talking about specifically. So really great suggestion.
question. Thank you.
question is Patricia Reedy. Line is open.
Thanks. So many great areas in this study. I have a particular interest in the team-based care case studies. And I understand the focus is have to do with combining primary and behavioral health care services integration. I wonder if part of that is also going to focus on the following. We've done some work here in Illinois in another project having to do with workforce development where we identified and we hoped we would be able to do something, but we didn't. But the problem we identified is that whether are the primary and behavioral health providers or whether they're just behavioral health teams, many times there's a lack of ability to actually know how to work on and lead a team. And that skill set sometimes, especially in an inpatient area, can be as important as understanding the mental health and psychiatric issues involved. So I was wondering if you are going to, maybe it's just a case where the words we use mean two different things, but I wonder if the actual skill set of working on a multidisciplinary team and or leading one is something you might be looking at.
It is. Good question. I think it's important to kind of reiterate that when we're thinking about team-based care and integrated care, both physical and behavioral health, but also co-occurring mental health and substance use disorders, and how team-based care might look for that as well. But yeah, we're really trying to frame this in terms of workforce factors. So although we're definitely interested in how service delivery is happening, from our perspective, the real key workforce questions for us are how do you get your team to do this well? How do you train them, or what skills do they need to function appropriately, regardless of which they are, behavioral or kind of primary care or physical health care. Kind of what are the aspects or the strategies that these organizations are using to facilitate a team-based care model.
Thank you. Showing no questions. Again, for questions or comments, press star one, please. From Renata Henry, your line is open.
Oh, thank you. I know you put some milestones in terms of when certain information would be out and reports. Could you briefly summarize the expectations at the end of year one? I'm thinking about this from a perspective of a training TA center, specifically for the substance use disorder workforce, but certainly that's a very broad workforce. How alignment of what the addiction technology transfer centers, or for that matter, any other training and TA center that SAMHSA and or HRSA funds, this information can be utilized in the application of our work.
Yeah, that's great. In terms of the timeline for when this information would be available for use, typically all 12 projects are supposed to be wrapped by August 31st. We're probably going to be able to do that with 9 or 10 of the 12. I think a couple are probably running a month or so behind for various reasons. But I would expect the majority of at least preliminary information to be available late summer, early fall, and we'll certainly provide more in-depth reports as appropriate. in the months after that. So in terms of, that would be the timing. In terms of how it could be available to you, we're certainly happy to work with Ann and others at SAMHSA to make sure we can get as much information to you as you'd like.
Thanks. That's very helpful.
Questions or comments at any time, press star one, please.
For the next question, this is Ann. Robin and I and Angela will certainly sit down and develop a dissemination plan for the information that the Research Center is developing. It's just very exciting, so we'll talk about how we can do that in the best way. All right, unless there are anybody waiting to submit a question or make a comment, it's like we're kind of winding down.
And we're showing questions at this time.
Let me thank you, Angela and Robin, both for coming and doing this presentation, and for everyone who's participated. I think your comments and suggestions really help to flesh out kind of how we think about moving forward and what we need to make sure we're paying attention to. Robin, is there any closing comments that you would like to make?
Just to echo your big thank you. This is so exciting for us to move forward with it, and these ideas will really help us as we think about how to get out the Year 1 project results and how to develop the Year 2 and Year 3 projects. So this is great. And just a big thank you to you, Angela, for doing this. I know it's been a crazy year to kick off the center and such a dynamic year in behavioral health with such huge needs. So this is timely and important work, and thank you.
Everybody, thank you very much for your time and for paying attention. We'll make sure that this webinar that is recorded, you will have the information and the access to it. So thank you. Have a wonderful rest of your day.
Participation, that does conclude today's conference. You may disconnect at this time.